Okay, so I wanted to talk a little bit about Ozempic or Wegovy or Trulicity or Mounjaro. These are GLP-1 receptor agonists, and it seems like in LA half the people are on Ozempic or Wegovy actually. Most people are probably on Wegovy, not Ozempic, because they're actually the same drug. Wegovy and Ozempic are both semaglutide, and some people pronounce it semaglutide and some people pronounce it semaglutide. So I'm going to pronounce it semaglutide because I think that's how most people pronounce it. But they're the same drug, and Wegovy is FDA approved for treatment of obesity, and Ozempic is not approved for obesity; it's approved for diabetes. But they're exactly the same drug. It just they're a different trade name, and the dosage is a little different. But the drug is exactly the same. And semaglutide was used for a long time as a diabetes treatment, and then they noticed that when they used it for diabetes treatment, people lost weight on it, and then it became a weight loss drug, and that is when it kind of entered the popular um, zeitgeist, and this has become very, very popular, and lots of people are on it. So a lot of people are asking me about it, and a lot of my patients are on it, and it does affect surgery because you can't have surgery within 5 days of having an injection of one of these GLP-1 receptor agonists, because it slows down your gastrointestinal tract, and you're more likely to aspirate when you go under general anesthesia. So they really don't want you to do any elective surgeries within 5 days of injection. But anyways, I was very interested in this, so I thought I would look into it and talk to you about it, you guys. And my first thought was, I had mixed feelings about using pharmacotherapy or using drugs to treat what is essentially a lifestyle disease. And then I thought about it some more, and I'm like, this is what we've been doing for decades. We're treating diabetes, high blood pressure, hypercholesterolemia, dyslipidemia. These are all lifestyle diseases too, and we treat those not by treating the root cause, which is lifestyle, but by treating it with pharmacology, with drugs. And so I guess it stands to reason that we're going to treat obesity the same way. And obesity, as everyone knows, is a major problem, especially in the United States. If you look at this, back in 1975, obesity is defined as a BMI, or something called a body mass index, of 30 or above. Back in the 70s, it was like 11% of Americans were obese. Over the past 50 years, it has more than tripled, and we're sitting at 37% back in 2016. I believe now we're in the low 40s. We're at like 43, 44% in America for obesity, and very soon we're going to be 50%. So more Americans will be obese than not obese in a few years, and that's where we're sitting at. If you look at, this is how you calculate BMI. If you just type in Google BMI calculator, the first thing that shows up is the the NIH calculator. And so, like, if you're a woman and you're 5'4" and 180 pounds, if you compute BMI, then you would be obese, 30.9. If you're a man, let's say you're 5'10", and let's say you're 240 pounds. Let's see what that comes out to. Yep, obese. 190. Not obese. 205. Let's see. Where's the cutoff for a 5'10" male? Okay, 210. Above 210. Of course, now BMI is not the perfect calculator. If you're a very muscular person, you can be heavy, and this calculator would say that you're obese, but clearly you're not obese. If you're a NFL linebacker and you're 5'10" and 240 pounds of muscle, you're not obese. But for most people that are not strength athletes, this BMI calculator is going to be pretty good. And then these are some pretty sobering maps from the CDC looking at obesity trends over time in the United States. If you look at this was back in 1985, and you see that most of America was below 10%. And there were a few Midwest and Southern states that were between 10 and 14% obesity in their adult population. As time goes on, year by year, you see that the darker blue color, which is the 10 to 14%, gets larger. And now they have to add an even darker color that represents 15 to 19%. And you see that's taking over the population. And then now they add a new color that's over 20%. So now, at this point, there is not a single state that is less than 15% obesity rate. So the thinnest states in the country are now at 2002 more obese than the most obese states were back in 1985. And then as we go on, they add another one of 30%. And in 2010, where this ends, you see that large swaths of the southern and midwestern United States are over 30% obesity. And the thinnest states are at 20 to 24% obesity. Then they continue this. And if you look at this, oh, sorry about that. Okay, so it starts at 2011. And you see, as it goes on, the red color just takes over. And this is our current scenario as of 2022, where most of the country is in the 30s to 50s, so 30s to 40s, and a few random states, California, Colorado, Vermont, Massachusetts, New Jersey, are sitting at 25 to 30%. So that's where we're at. And this is obviously a really complicated problem. It's not like people in 1980s had more self-control or just were fundamentally different people than we are now. Their genetics are the same and their psychology is probably similar, but the environment has obviously changed, and there are multiple things that lead into this. One of the things is we're surrounded by endocrine disruptors in our clothing, cosmetics, food, pesticides, all these things. There's all these endocrine disruptors. They are banned in the EU. The EU bans like over 1,000 of these. The US bans like 11 of them. But they're fairly ubiquitous, and it's very hard to avoid these things. And these things more than likely are probably contributing. Another thing that contributes is the amount of sugar in our foods. We eat a lot of processed foods. And you can remember I had this video a while back. Basically, every adult American on average eats their entire body weight in sugar per year. This was in 2000. The average American was eating about 50 some kilograms of sugar per year. That's about 120 pounds. And it's been climbing ever since then. So that's another problem. The other thing is our microbiome affects our obesity. And then also the use of antidepressant drugs has skyrocketed in the 90s, and many people are on antidepressant drugs, and those are known to cause obesity. So now we have problems that are side effects of other drugs that we're taking, and we're using another drug, Ozempic in this case, to treat the side effect of, for example, Prozac. Remember, like in the 90s, Prozac and all that stuff was just like you could see it on the news and in advertising and in print advertising, TV advertising. And so antidepressant drugs are very common. So there's multiple reasons. The way that our cities are designed such that walking and biking is less common, and the amount of exercise people get, multiple reasons why obesity is climbing. But we have now decided as a society and as a medical community that we're going to treat obesity with a medicine and not by treating the root causes of these problems, which has kind of been the pattern in modern medicine. All right, so what is Ozempic or semaglutide? These are all called GLP-1 receptor agonists. GLP-1 stands for glucagon-like peptide 1. And what that is it's a peptide that has many effects, and GLP-1 agonists, receptor agonists, basically means it's a molecule that acts like GLP-1. It binds the receptor and acts like it. And so this is liraglutide and semaglutide, and you can see that they are very similar. These are amino acid sequences of the peptide, and you see a couple of differences, like semaglutide has this synthetic amino acid substituted for the alanine at the second position here. It's the number 8 position in the propeptide. The first 6 are cleaved off. And what this does is it keeps this protease from cleaving it so that it stays in the bloodstream longer. It won't get broken down. And then both of these drugs have a linker at this lysine, and this linker basically helps it bind albumin in the blood so that it stays in the bloodstream longer. So these have a longer half-life than the natural hormone, and they stay in the bloodstream longer, which is what they want as a drug. And then what are the effects of this GLP-1? They have effects, as far as we know, in multiple organ systems. These are just the ones we know about. There's probably other effects that we're not aware of, but basically in the liver, it decreases glucose production. In the pancreas, it increases insulin synthesis and secretion, protects the islet B cells. This is one of the biggest effects. So the biggest effect in terms of weight loss is it slows down the GI tract. So food doesn't move through, which makes people feel full faster. It has a lot of cardio protective effects, which are good, and also a lot of neuroprotective effects, which are good. But also the thing that's most interesting is it signals an increased, the signal level of satiety from eating goes up faster. So those are this effect and this effect are the main effects that people are looking for when they're using it for weight loss drugs. All right, so do these work? This is one of the big trials. It was called a Step 4 randomized clinical trial. This was published in JAMA in 2021, and they looked at maintenance with the glucagon-like peptide 1 receptor agonist. And they use semaglutide, 2.4 milligrams. That's why that's the dose of Wegovy because of this trial. And what they did is they had a total of 902 participants. They received once weekly subcutaneous injections. In 20 weeks, the first 20 weeks, people lost an average of 11% of their body weight. That is a significant weight loss. So for a 200-pound person, that would be 20 pounds. That's a significant weight loss in a 20-week period. Then after 20 weeks, they flipped them, and they had some of the patients switch to a placebo at 20 weeks to see what happened. And what happened is the people that stayed on it for the next 48 weeks lost an additional 8% body weight. And then those who switched gained back the body weight. All right. And it was a systemic review looking at all the other randomized clinical trials. They basically show that all of these do the same, and maybe semaglutide is the most effective of the ones that we have right now. And so what we know is it causes those two major effects. It increases your satiety, and it slows down motility through your GI tract. But it seems to have some very, very interesting effects beyond that. Not only does it seem to make people full faster, it seems to make people not want the quote bad foods like the sweets and the fatty foods as much as they used to. It has some effect on the brain that we don't fully understand. And what's interesting is it shows that it could be useful in treating other addictions. So food is sort of like an addiction. Food addiction is sort of, being wanting food that's quote bad for you, sweets and fatty foods and salty foods, that kind of thing. Those release dopamine in your brain and make you feel good, and that's similar in like opioid drug abuse and stuff. And there's some studies that show that these GLP-1 receptor agonist drugs could be useful in that space. And there was this big Scientific American. So it seems to treat other addictions, and it could even treat like gambling addictions and drug addiction, alcohol addiction, all these other things. So that is another very interesting effect of this drug, and is a positive effect of this drug. Now, every drug has side effects, and it's not a free lunch. So what are the adverse effects of GLP receptors? they are the most common symptoms associated with GLP-1 receptor agonists are GI symptoms, mainly nausea. The other common ones are injection site reactions, headache, nasopharyngitis. So you have inflammation in the back of your nose and the back of your throat. And they are cardioprotective, so that's a good thing. But there's some other rare problems that it can cause. You can cause some kidney injury and pancreatitis, pancreatic cancer, and thyroid cancer. There's a very specific type of thyroid cancer, so we'll talk about it more. There's this up-to-date article, and we'll go through the adverse side effects of this. So the side effects of GLP-1 therapies are predominantly gastrointestinal, particularly nausea, vomiting, diarrhea. They are frequent. So 10 to 15%, 10 to 50% of patients have some amount of nausea, vomiting, and diarrhea. These symptoms tend to get a little better with prolonged use. There's some adaptation to it, but these are very, very common. 10 to 50% of patients have that. And then nausea is the most frequent side effect of these things. Then pancreatitis is another thing. Pancreatitis has been associated with the GLP-1 receptor agonist. It doesn't happen commonly enough that they can say for sure it's a causal relationship, but it happens enough that they know that there is a relationship between the two. Pancreatitis can be a very dangerous condition. It has an up to 40% fatality rate if you have a severe case of it. So that's something to think about. The risk is quite low, but it's not zero. And there have been case reports of increased risk of subclinical pancreatic inflammation, pancreatic cancer, and neuroendocrine tumors. So that's pretty serious. Then gallbladder diseases, it has an increased rate of cholelithiasis and cholecystitis. These are gallbladder problems. So this is the thing that people get cholecystectomies for. They get your gallbladder removed because people have problems with this. And people that are obese have a higher rate of this, and those are the people that are going to be treated with this drug. So that is another thing. Hypersensitivity reactions, that can happen with any drug, so that's not unique to semaglutide or any of these GLP-1 receptor agonists. And then kidney, there have been case reports of kidney failure and kidney problems with this. So that is a problem, because another interesting thing is these drugs kind of make people less thirsty, so there's less water intake with these drugs, as well as less food intake. There have been some reports of thrombocytopenia. That's like platelets are a little cell that help you clot, and it reduces, it can cause a lowering of that level. And this is some of the other things. So it is unclear. So when they gave this to rats, it gave some of them medullary thyroid cancer, which is from these parafollicular C cells that are in the thyroid. And so it's unclear if this happens in people, but that is the GLP-1 receptors in C cells are there, but at a lower level in humans. So that's not entirely clear, but right now people say that if you have a family history of medullary thyroid cancer or MEN2A, that you should not take these, because the rate is increased in these people. So one nested case control found a increased risk of both medullary and all thyroid cancers in patients that were prescribed GLP-1. But this did not control for key factors including body mass index, history of thyroids, or family history of thyroid cancer. Those would be important things to control for. Okay, so that's kind of where we're at. So the drugs are effective for reducing weight, but you have to take them forever. It's not like a thing you can take and then you get off of it and you maintain the lower weight. As soon as you get off the drugs, you regain the weight that you lost. So it's a chronic drug, which obviously pharma companies love that. You have to stay on it forever to get the results. And obviously the better option, but the more difficult option, is to change your diet and your lifestyle. Those changing to a healthy diet and exercising only has good side effects. There's no bad side effects to this thing. The bad side effects of this drug are nausea, vomiting, gastroparesis, slower emptying, flatulence, possible pancreatitis, possible kidney failure, possible pancreatic cancer, possible medullary thyroid cancer. So a lot of possible bad side effects. The side effects of a healthy diet and a healthy lifestyle are only good side effects. So that's the preferred method, but obviously that's really hard for people. It takes a lot of work, a lot of commitment, and this, doing an injection is obviously much easier. But again, it is a temporary thing, and you have to stay on it forever. But it is effective, and it has these very interesting neurologic effects where it seems to treat other addictions rather than just food addiction. All right, hopefully that was interesting. I'll link a lot of these studies below in the description. And if you have any questions or comments, I read all of them.